MDTs, solving our problems, and a very prompt responses on the WhatsApp has not only saved lives, but we can now have a countless people who have got benefited from his expert opinions in the field of ALL and CLL. And personally, I can say at least 15 people with his help has seen another year, 2025. So with this introduction, Department of Hematology continues to grow, and 3-day genomics has become quite a remarkable sensation in the country, where in 3 days you can get myeloid NGS as well as lymphoid and leukemia NGS. With this, I hand over to Dr. Nikhil, who has been doing a wonderful job, and he'll introduce our clinical lead today for CLL. One disease, one doctor will be our motto in 2025, and we hope to replicate the legacy of Dr. Nitin Jain in the country through the eyes and the minds of Dr. Anusha. Over to Dr. Nikhil.
Thank you, Dr. Bhargav. Thank you, Dr. Bhargav, for that kind introduction. So, welcome you all to the Innovations in Hematology webinar series, where we have been trying to answer a clinically relevant question every month with a world-renowned expert. And today, we are happy to have Dr. Nitin Jain with us, who is one of the pioneers in the field of CLL. He would be speaking to us regarding time-limited treatment strategies in CLL. Before I go on to introduce him, as more and more of our patients, younger population is detected with CLL, that question always comes up in our mind, whether we need to put them on limited treatment strategies versus put them on lifelong therapy and the toxicity that comes along with this. This is a dilemma that comes in every time we see a CLL patient and counsel them for treatment, definitive versus indefinite therapy. So we would love to hear from Dr. Nitin Jain regarding advances in this field and what are the best options for treating our CLL patients in 2024 and beyond. We are also happy to have with us Dr. Anusha Swaminathan, who is a clinical lead for our CLL program in Fortis Institute of Blood Disorders. She is joined in, and we would be happy to discuss a few of our CLL patients with Dr. Nitin Jain after his talk. So moving forward, Dr. Nitin Jain needs no introduction. He is a professor of medicine in the Department of Leukemia at the University of Texas MD Anderson Cancer Center. His research interest mainly focuses on CLL and ALL. Since 2021, he has served as a director leukemia CAR-T program within the Department of Leukemia at MD Anderson. He has numerous publications in prominent national and international journals to his credit. Dr. Jain is also the principal investigator for several investigator-initiated trials in the field of CLL as well as ALL. Some of them include combination treatments and time-limited treatment strategies in CLL, of which we are planning to discuss a few, checkpoint inhibitors in richer transformation, role of JAK2 inhibitors and other therapeutic strategies in PH like ALL, novel CD22 antibody drug conjugates, and venetoclax-based combination therapy in ALLs. So before I hand over the session to Dr. Nitin Jain, I would also like to introduce our speaker for the next webinar, which will be on the 17th of January, 2025. So we'll be starting off the year with a webinar on management of DLBCL with CNS involvement, where Dr. Priyanka Pofali from the University of Wisconsin would be speaking to us on the 17th of January. So I'll stop sharing my screen, and I would like to invite Dr. Nitin Jain to deliver the lecture on time-limited treatment strategies in CML.
Give me a second, let me share. Can you see my screen?
Yes, sir, your screen is visible.
Perfect. So first of all, really delighted to be here with you guys. It's a morning time in Houston, evening time for you guys in India. And thank you, Rahul, for the very kind introduction, and also Nikhil. So the task assigned to me was time-limited treatment strategy of CLL. And this is a perfect topic because some of you maybe were at the ASH meeting or may know some important data was presented at the ASH meeting, which I think will make more time-limited strategies for frontline CLL a more of a reality, and more people may start using it. So my talk really will be focused on frontline therapy of CLL, but happy to discuss obviously other aspects you have or questions you have. So let's delve in. These are my financial disclosures. So before I get started with the time-limited therapy talk, I think it's important to recognize that ibrutinib was approved for CLL in February of 2014, so just about 10 years ago. So this is like a decade of progress of targeted therapies which have been made, which really has changed the treatment paradigm, that now we are, really not using chemotherapy at all. Chemotherapy is abandoned, and 100%, at least in the United States, and I'm sure many other countries are who can access to these drugs are completely have abandoned chemotherapy. Now, what are the main targets we are targeting with in the CLL therapy? So this is a recent review article we did for the journal Lancet, where you can see there are 4 BTK inhibitors which are currently approved, 3 in the frontline setting, namely ibrutinib, acalabrutinib, and zanubrutinib, and we'll talk about that. We have venetoclax, a BCL2 antagonist. We have C20 antibody, of which there are 2, rituximab and obinutuzumab. And there is data that obinutuzumab is better than rituximab. So in our practice, we have really moved to obinutuzumab as a preferred C20 antibody. And there are other drugs, CAR-T as well as PI3 kinase inhibitor, which are approved in the relapsed refractory setting. We won't be talking about them today because I'm going to focus on the frontline therapy with target therapies. And as I mentioned, this field has continued to evolve since 2014, when first ibrutinib was approved. Now we have multiple BTK inhibitors. Last year, zanubrutinib and pirtobrutinib were approved. This year, 2024, lysocell CAR-T was approved for CLL. And there are multiple strategies which are coming along. Some nice data presented with C20 bispecific, BTK PROTAC. So I think those are at the ASH meeting. So those are coming along nicely, and we'll see how they kind of pan out in the next few years. Now, before I start, I wanted to give us some slightly historical perspective. This is a review article I wrote with Dr. O'Brien just about 10 years ago in Blood, where we talked about frontline therapy of CLL. And, this is something which it will be like more historical now, talking about FCR, BR, chlorambucil, 17p patients getting alemtuzumab. And this is history. This is obviously is completely obsolete now, just looking about it. I was recently looking at some older slide decks, and I came across this slide, and I was like, oh, let me put it just to see how dramatically different the landscape is now as opposed to 10 years ago. And the landscape is pretty much non-chemotherapy. So at least in the United States, and I guess you guys have access to acalabrutinib and ibrutinib and obviously venetoclax in India, but at least in the United States, we have 3 indefinite therapies, continuous daily therapy, ibrutinib continuously, acala with and without obinutuzumab, and zanubrutinib. So these are continuous daily therapies. Or you can do a time-limited approach, 1 year of when obinutuzumab is approved, 1 year of when ibrutinib is approved ex-US, like in Europe, Canada, and Brazil, and many other countries, but not per se in the United States. And then, I think the expectation from the ASH meeting, and I will show you data from the Amplify trial, is that 1 year of venetoclax plus acalabrutinib, maybe with and without obinutuzumab, may get approved next year. But again, we don't know for sure, but that's what the expectation is. So we will have, a new and important second generation BTK inhibitor, namely acala with ven, hopefully coming into the market and getting FDA approval hopefully soon. So that I think is an important study, and we'll talk about that. Now, very briefly, before we talk about time-limited therapy, I think it's important to see what does continuous therapy, what is the data with continuous therapy and where we are. So this is the original trial, RESONATE-2 study, continuous ibrutinib versus continuous chlorambucil. And now we have, I think this is the final analysis, where we have median PFS of about 9 years with continuous BTK inhibitor, namely ibrutinib. So this is the longest follow-up of a phase 3 study. And so this was quite remarkable, right? You're getting 9 years with BTK inhibitor. But the problem is you're taking BTK inhibitor every day, or practically every day for the 9 years. So it's a continuous daily therapy, but it works very well. It does improve survival compared to chlorambucil. And this was kind of pretty neat. This is a study which came out recently from Paulo Gea and colleagues, where they asked a question for these patients on the randomized studies, what is their survival with ibrutinib versus age-matched general population of the same age and everything. And it's quite clear, obviously, that ibrutinib survival, patients on ibrutinib, they have the same survival as age-matched general population. So these are CLL patients getting frontline therapy. Obviously, these are patients who are on these trials, so they're generally fitter and kind of maybe, but nonetheless, I think this is quite intriguing and interesting that patients with ibrutinib are doing same as age-matched population, meaning the survival is same as general population. So that's ibrutinib. But as you know, given data with the second generation BTK inhibitor, we have practically moved away from ibrutinib in the United States, and we are preferentially using second generation BTK inhibitor, namely acalabrutinib and zanubrutinib. So acalabrutinib, I know, is available in India, and I think is being used quite commonly these days. Acalabrutinib, this is the randomized study which led to the approval of acalabrutinib. Acala-obin versus acala alone versus chlorambucil, obinutuzumab. This was data not from the ASH meeting, but the previous update. There was no update at ASH for this trial, but acala-obin and acala alone clearly outperformed chemotherapy, and this led to the approval. Notably, adding the CD20 antibody improved the PFS at 6 years by about 16%. And one of the reasons why that is if you look at the MRD rates in this, we generally don't talk about MRD in non-ven containing regimens, in general. But if you look at it, acala alone, 3% or 10% of the patients became MRD negative, and this is MRD undetectable by -4. But if you do acala-obin, a much higher rate of 40%. So certainly obin adds to the depth of remission, and maybe that's what's, if I go back, is driving this improvement in PFS, because the only difference between the two arms is 6 months of obinutuzumab, early on they get. But both groups are continuing acalabrutinib. So I would say most of us were surprised to see this separation of the curves. We thought that it would be pretty similar, or not a dramatic difference, but it is there. I'll skip this slide. Now, at the ASH meeting, we also saw an update on zanubrutinib. So zanubrutinib is from BeiGene. That's another BTK inhibitor. I believe it's not yet available in India, but maybe coming soon. So this is a trial where compared Zanu with BR, and we saw a 5-year update in a poster session where you can see 5-year with zanubrutinib, the PFS is 76%, better than BR, 40%. So another study of the many studies which have made the same argument that chemotherapy is not the answer for these patients. If patients can afford it, I think target therapies are the way to go. And we also know that these patients, mutated versus unmutated IGHV doesn't really matter when you use continuous BTK therapy. And this is the argument here. The top curve is mutated IGHV, slightly lower curve is unmutated, but they're practically similar with zanubrutinib. So zanubrutinib is another very important drug in the context of CLL. Again, I think, and in the relapse setting, there is data that Zanu has improved PFS than ibrutinib. So it's a at our center we use both acalabrutinib and zanubrutinib quite regularly. I don't know if there's strong data to say one is better than the other because they have not been compared head to head. So I think it's just your practice pattern availability, and maybe in India availability and the cost may be an issue to decide which of the second generation BTK inhibitor you would pick. So these are great strategies. If you use continuous BTK, patients are doing remarkably well. But the problem is that you have to take these drugs for long. It adds to the cost, especially in the Indian perspective, and it would also add to the toxicity, AFib, hypertension, bleeding issues with BTK inhibitor. So for the last, I would say, many years, strategies have been developed to do time-limited therapy. And if you think about it, when we're doing FCR, BR, I mean, obviously you guarantee their chemotherapy, but you do 6 cycles and then you stop and then you just watch and wait. But then when the BTK inhibitors came about, because they were not leading to kind of deep remissions, but the patients were doing fine, the argument was, oh, you need to take them continuously forever. But then the venetoclax-based regimen came about, and the argument became, no, you can cut down on the treatment. And somehow 1 year just arbitrarily has been used for many of the trials, which I will show you, though it's unclear if 1 year is the right strategy. And I will show you some data with longer BTK-VEN combinations. So the first study in this regard, a major study, was CLL14 study, which combined ven obinutuzumab with ven chlorambucil obinutuzumab. Now, this study was also not updated at ASH, so this is older data set, but this is the most updated data set. 6-year PFS is about 53%. So you get 1 year of treatment, and rest is treatment free. So which is actually not bad, your 6-year PFS, because potentially you can retreat these patients and get another mileage or benefit out of it. You can retreat with the same ven obinutuzumab. So this is actually a regimen quite commonly used in the United States as standard of care therapy these days, because it's a 1 year time limited approach, and this is the only 1 year time limited approach available in the US. The problem is, and first of all, you will have infusion reactions from obinutuzumab. It's an infusion, so you need IV infusion chair time in the infusion unit, and TLS monitoring and whatnot, and that has created a bit of a logistical challenge for many physicians and centers to use it. Now, one thing which is emergingly becoming clear, when ibrutinib, we were using BTK inhibitor, IGHV mutation was not really mattered. I showed you the data with zanubrutinib, curves were overlapping, similar data with Acala and ibrutinib. But when you're using time-limited approaches, because we know unmutated V gene patients, the cells cycle faster, they will likely have a shorter PFS. And this was actually, so this is the CLL14 study, ven obinutuzumab. If you look at the two blue curves, early, maybe by 3 year, the curves are still pretty similar, but then they start to separate. The top curve is mutated IGHV. The bottom curve here is unmutated IGHV. And these are my own notation on the slide just to make it a point clear that almost a 30 percentage point PFS difference between mutated IGHV and unmutated IGHV, which has led some people to say that for mutated IGHV, VenG is a good strategy because you're getting such a prolonged PFS. But maybe for unmutated, we need to do something different. Maybe some people say, oh, maybe continuous BTK will be better. But I don't make that distinction. I think for unmutated also, you're doing very well, and potentially you could retreat them if need be, or use a BTK inhibitor at the time of relapse. Now, one group which does not benefit much, with the caveat there are only 25 patients in the study, is the P53 patients, where the 6-year PFS is quite inferior. And really, currently, as of now, the standard would be a continuous BTK inhibitor therapy. One thing I would like to mention is that if you're using a venetoclax-based regimen, whether it's ven obinutuzumab, for that matter, maybe if you're using ven rituxan, ven ibrutinib, ven acala, or something like that, neutropenia rate may be in the 40 to 50, 60% range. And this is in the CLL14, 52% neutropenia grade 3 or 4 with ven obinutuzumab, and 14% grade 3 or 4 thrombocytopenia. Now, what you get with ven-based regimens is MRD negativity. So this is based on NGS. The green here are MRD undetectable at different levels of sensitivity. You can see once you finish therapy right around here, about maybe 70, 75% of the patients are undetectable MRD, but over time, patients do tend to lose MRD status, and actually at 5 years, only about 8% of the patients were still undetectable MRD. So Eventually, these patients will relapse. Who have become MRD positive, most of them will eventually relapse. So the curve for the CLL14 will eventually continue to come down with time. So how are we making these treatment decisions? Again, we have at least availability of ibrutinib. We have second generation BTK inhibitor, and we have a time-limited obinutuzumab. There are pros and cons of these approaches. At least ibrutinib is now out of we are not really using ibrutinib, and the argument becomes between BTK inhibitor and Ven-G, at least in the US. And again, there are pros and cons of these approaches, which are listed on the slide here. I would say in my practice, I use a lot of obinutuzumab outside of a clinical trial setting. It's a very well tolerated regimen, though initially you have to just watch for obinutuzumab infusion reaction and just be aware of the neutropenia rate, where you may have to hold the drug, give growth factors, GCSF and things like that. Now, what about the new time limited approaches? So we talked about BCL2 CD20 ven obinutuzumab, but what about combining BTK and BCL2 like ibrutinib ven or acala ven? Or what about all three? Why don't we use all of our best drugs together and kind of make a make it a triplet regimen? And we have options, right? We have covalent BTK inhibitor, ibrutinib, acala, zanu. We have non-covalent BTK inhibitor, pirto, and there is also nemtabrutinib. It's grayed out because it's not FDA approved yet. BCL2 inhibitor, we have venetoclax, but some of you may know there are two other BCL2 inhibitor, namely sonrotoclax and lisafroclax, which are in phase 3 studies in CLL. And so we'll see how they pan out. And then CD20 antibody, obinutuzumab, though certainly there is rituximab as well, but really obinutuzumab is the preferred antibody, which is being used in different regimens. Now, when we say combining a BTK and BCL2, for example, ibrutinib venetoclax, it's not just A plus B. There is also a scientific rationale of combining the two. Ibrutinib downregulates MCL1, which may have a benefit in terms of synergizing with venetoclax. So we and many other groups about 10 years ago or started planning these trials with ibrutinib plus venetoclax, because ibrutinib was really the only BTK inhibitor kind of available at that time to say. So we elected to combine ibrutinib plus venetoclax together. I think so. Okay, got it. So so this was an update from the last ASH meeting, and we are working on another update now for our publication. This is a trial done at MD Anderson, combining ibrutinib plus venetoclax together for high-risk CLL. You can see they had to have these risk features or age 65 years or older, but majority of them had some high-risk feature. Now, a big difference between this study and many other study I will show you is 2 years of therapy. Everyone got 2 years of ibrutinib plus venetoclax. There was no provision of 1 year of ibrutinib plus venetoclax. Everyone by default got 2 years therapy, though there was a provision of a third year of therapy for MRD detectable patients. So that's an important distinction, 2 years of psychotherapy for everyone. We treated between 2016 and 2019 at MD Anderson 120 patients, which are listed on the slide here. These were genetically selected to be high risk. So you can see 86% of the patients were unmutated V gene, and 23% of the patients had either 17p or p53. So a higher risk patient population. At that time, we were doing flow cytometry in the bone marrow as our preferred MRD method. You can see as a best response, 72% of the patients become undetectable MRD by 10 to the power minus 4 sensitivity by flow cytometry. And this actually correlated into a relatively nice PFS, 5-year PFS of close to 90%. And then when we looked at patients with 17p or patients IGHV status or not, they seem to be doing equally well. Though again, the caveat here is only 27 patients with 17p, only 16 patients with IGHV mutated, because here our group was enriched for high-risk genomics of IGHV unmutated. So that's MD Anderson data. As I said, this is a 5-year data set. We're working on a 6-year update for a publication now, hopefully in the next few months. At the same time, Captivate, a very large study, international study was being done, kind of the same treatment concept, ibrutinib and venetoclax together, but they elected 1 year of therapy. So 1 year of ibrutinib plus venetoclax. And this was their update, and this is the most recent update. 5-year PFS is about 67%, which is numerically a bit lower than, I showed you 89% for MD Anderson study. But then look at this, 27 patients with 17P, and their 5-year PFS was 41%. So, this is, I would say, a bit, somewhat underwhelming, where you would hope that by giving ibrutinib plus venetoclax, 17P patients may be doing better, but actually they don't appear to be. PFS is only 41%. And overall, so PFS appears to be a bit lower at 5-year at 67%, because the next study I'm going to show you is the FLAIR study. Again, this is from last ASH. This was not updated at this, where they also use I plus V, but they had a different MRD guided strategy where they do 2 to 6 years. So very long I plus V, not 1 year. Actually, you could be from 2 to 6 years of I plus V. So very long duration, I would say, on an average. They did say that about half of the patients got 2 years, 63% got stopped at 3 years, and so on and so forth. So average, they were continuing treatment for more than 2 years. And this was the result, 3-year PFS. Fantastic, 97%. I mean, this is probably the highest PFS in a randomized study, for patients in a randomized phase 3 study, with I plus V we are seeing, or any regimen for that matter, and compared to FCR. So really fantastic PFS and fantastic OS as well. So now I've shown you about 3 regimens with this time-limited approach. And these are summarized in this slide here, which I made. This is the most updated data of these data sets. So MD Anderson, 2 years of therapy, I plus V. FLAIR UK, 2 to 6 years. Captivate, 12 cycles. And with the caveat of cross-trial comparisons and whatnot, 5-year PFS of 90%, 3-year PFS of 97%, and a 5-year PFS of 67%. So I think, to me, 1 year of I plus V may not be sufficient for patients. And I think the longer you continue kind of makes sense, maybe better your PFS will be. Now, what is the right mix? Should it be 2 years? Should you check MRD at 1 year? And if it's positive, continue second year. I think that is unknown, but I think strictly just doing 1 year of I plus V, in my opinion, may not be ideal for patients. This is a summary slide. I will come back to that in a later slide deck. And now I plus V was also studied with chlorambucil obinutuzumab for a randomized study. This was a study which led to the approval in all over the world of ibrutinib plus venetoclax. But one of the reasons, the main reason, FDA did not approve this. Look at the survival. The red one is I plus V. The black one is chlorambucil obinutuzumab. And paradoxically, early on, there were more deaths actually in I plus V. And later it catches up and doing well. But these early deaths were many cardiac issues from ibrutinib. And so there was a concern that, I think these patients, this is kind of toxic for these older patients. And therefore FDA did not approve it, though again, it is being used quite commonly in many other countries in Europe and others, I plus V regimen. Now, one question you may have is that, okay, you're talking about doublets and triplets, and we'll talk about triplets in the next slides. But if I use all my best drugs now, what am I going to do at the time of relapse? And I would have just finished all my, armamentarium to use. But the beauty here is that these are time-limited approaches. You give for 1 year or 2 years or some kind of MRD-guided therapy. And when you relapse, when you're not on treatment, you do not have resistance mutations and you're sensitive to the drugs again. This is from the Captivate trial, where any patients who progressed after therapy, they did not have any of these resistance mutations, and subsequent retreatment worked. So again, when you stop therapy, you progress 2, 3, 4 years later, you can reuse the same drugs which you used in the frontline setting. So that I think is an important aspect to remember, that you do not lose those agents to use in the relapse setting. So I talked to you about some of the ibrutinib doublets because that's where many of the data sets are. But field is continuing to evolve. We have now doublets of acala-ven. We have Zanu-ven doublet. We have Zanu-sonrotoclax doublet. We have pirto-ven doublet, and these are all frontline studies, and I listed the trials or the centers they are being conducted. We have ibrutinib triplets, acala-ven-obin triplet, Zanu-ven-obin triplet, and also pirto-ven-obin, which I will show you from our center from the ASH meeting. Obviously, there's a lot of data sets, and we're not going to go through them all, but I wanted to highlight maybe 3 data sets before we kind of summarize and come to the conclusion and answer your questions. So one of the very important data sets, which we are all waiting for at the ASH meeting, was the Amplify study. So the Amplify study was presented by Jennifer Brown in an oral abstract session at ASH last week, Monday, where this is the trial design. So these are newly diagnosed patients. These are younger patients because the comparator was chemotherapy. Patients got about 1 year of AV, acala-ven, or acala-ven-obin, so triplet, so doublet versus triplet, or chemotherapy. Now, I would say that, their primary endpoint was comparison of AV versus FCR-BR, and there were many other comparisons, but all comparisons were for chemotherapy. So though we will look at AV versus AVO, PFS and whatnot, the study is not meant to compare these two. It is meant to compare chemotherapy with these two arms. But nonetheless, we'll look at the curves. As I mentioned, these are patients on the younger side as appropriate because the control arm is, intensive chemotherapy. Large number of patients, about 300 patients in each arm. And this is the main data slide. So at 3 years, the PFS with AVO, so the triplet of acala-ven-obin was 83%, acala-ven was 76%, and then chemotherapy was lower at 66%. So this was the primary endpoint of the study. Primary endpoint of the study was comparison of doublet of AV versus chemotherapy, which clearly was met. Obviously, you can see the triplet is also doing better, numerically maybe slightly higher than the doublet, but both were superior. So this is the kind of the main data slide in a way, which again, should likely lead to approval of acala-ven or acala-ven obinutuzumab for patients with CLL, in the United States and many other countries in the world. Now, there's a bit of a further qualification of this data. So first is by IGHV status, because that's actually is a very important marker, genetic marker. And we know that IGHV mutated patients do well with chemotherapy. And as you can see here, if you do IGHV mutated, practically all the curves are somewhat overlapping, though chemotherapy is the lower, but AV and AVO are doing equally good. If you look at unmutated V gene, the curves tend to separate out, chemotherapy falls down, and here is AVO, and actually numerically seems to be doing much better than AV, but again, this is kind of within a trial comparison. So the curves separate out for AVO, for unmutated V gene, but for AV, mutated are doing well, maybe unmutated not so well. So this is somewhat more talked about, somewhat that AV is maybe not doing as well as the triplet for unmutated V gene. Now, one of the issues with this trial, kind of complicating issue, is that this trial was done during COVID time. And you can see there were many COVID deaths in 2021, 2020, 2022, but they were preferentially in the CD20 arm, as you may recall from COVID. CD20 antibody was leading to more deaths among these patients. Your recent use of CD20 antibody in some of the studies. So you can see FCR-BR 21 deaths, AVO 25 deaths, AV 10 deaths. So numerically lower, but that has skewed these curves because the investigators did censor then for COVID deaths, thinking that the COVID deaths were just what happened, and hopefully we're not seeing COVID deaths now. in the same proportion we had a few years ago. And so if you were to censor those out, then obviously the curves become really, really better. Look at the AVO curve at 91%. So certainly I think both data sets, AV and AVO, I think are impressive and I think will lead to FDA approval. Now, one thing which was surprising and a bit unexpected is the MRD rate. So the blue bar here is A plus V. Now, I showed you some data from MD Anderson briefly. With the ibrutinib, you expect maybe 60% MRD rate. But here with acala-ven, surprisingly, the MRD rates were like in 30-35% range, so much lower than ibrutinib 1. And this is something which is still unexplained why that is. And it has also been shown in another study from our center. AVO, acala-ven, fantastic MRD rates. And the green one is actually the chemotherapy. So this is a bit talked about, that AV arm is doing well, maybe not so well for unmuted V gene patients, but surprisingly and unexpectedly lower rates of MRD, which has been raised as a concern about A plus V regimen, which again will likely become quite commonly used regimen world over, but the MRD rate seems to be suboptimal. As I mentioned previously, if you're using any of these doublets and triplets, watch for neutropenia. 46% neutropenia in AVO, 32% neutropenia in acala-ven. And the other important, this doublet trial to say, and this was again not updated at ASH, this was from a previous ASH meeting, is this so-called CLL13 study, which also had a doublet, doublet versus triplet, obin, ibrutinib G and ven G, and again showing for mutated patients, ven G seems to be doing very well, but for unmutated patients, maybe there is separation of the curves between the two. So how kind of put these together data sets in the last, maybe 5-7 minutes before we go to question. So I made this slide, brand new slide this morning for you guys. So this is 5-year PFS in the first line CLL, trying to put everything together with the caveat of cross-trial comparisons, with the caveat that the patient age for some of the trials are older patients, some are slightly younger patient, and the caveat that some of these trials included 17 pay patients and some did not. The top three are the indefinite therapy, RESONATE-2, ELEVATE-TN, Sequoia, the regimens, and then you can see approximate PFS because some of these I had to kind of look at the curve and calculate what it approximately would be. It was not stated as such in the paper or the abstract, mutated versus unmutated. So you can see the indefinite therapy, ibrutinib acalazanu, mutated patients, 5-year PFS of about 80%, unmutated patients, maybe about 70%. Acala-obin seems to be doing actually a bit good there. But again, these are continuous daily therapy. If you do ven-obin for CLL14, mutated patients are doing well, and that's the argument that you can use ven-obin for mutated patient because you're getting almost the same PFS as continuous BTK inhibitor therapy. But for unmutated, maybe not so well. Then these are the 3 studies for I plus V, MD Anderson study 2 years of therapy, Captivate 1 year, and Flare 2 to 6 years, which I just alluded to. These are showing very high PFS rate, except again, unmutated patients not doing as well with 1 year of I plus V as I mentioned. But this I think is very interesting and maybe not so much talked about. CLL13 also happens to have a ven-obin arm. Now remind you, CLL14 had older patients, frailer patients. CLL13 had younger patients, more fitter patients. And if you look at the ven-obin here, the 4-year PFS is 90%, actually much higher than older patient ven-obin PFS. And here, unmutated, there was some concern, but here your 4-year PFS is up to 70%. So what I'm trying to say is that I think ven-obin is actually a very good regimen, and to kind of compare your drugs to, and I think it's a high bar, especially for mutated patients. And I guess we'll have to see if these doublets and triplets will beat that. And now I also plotted here Amplify study, which I just showed you. We only have 3-year data set. Again, triplet is doing fantastic. Acalaven is doing fantastic for mutated. So I think for mutated, you could argue BTK-Ven is could be a good idea, as is venobinituzumab. But maybe for unmutated patients, I think both seems to be slightly lower, but I think in my opinion still optimal. So I would think that I think Acalaven, in my opinion, will there will be a lot of uptake of this regimen world over once it gets officially FDA approved. Now, I want to show you maybe a few more minutes before we kind of close. So a lot of data sets I showed you, and Amplify study was the latest of them. But there are and there are many others, but there are two major ones, the trials which have been fully accrued. And we are maybe expecting next ASH to read out. And again, we don't know for sure, but that's maybe the expectation is CLL17, which is continuous ibrutinib versus Vengi, venibrutinib. So this will be a very nice study to see if continuous BTK inhibitor compared to time-limited approaches. And MAGIC study, which is going to compare Vengi, our kind of current de facto standard for time-limited approach, to Acalaven head-to-head. And that actually would be a very keenly, two of these randomized studies keenly watched, hopefully next year at the ASH meeting. Now, at the bottom, I want to show you a couple of new stuff. At the bottom here, there's a ongoing trial, which is actually fully accrued. It's called Vengi versus sonrotoclax plus Zanu. And again, sonrotoclax is the new, kind of a new BCL2 inhibitor like a venetoclax, and zanubrutinib is a BTK inhibitor. So this trial is fully accrued, randomized head-to-head study. And they showed some data, not from the randomized trial, but they had a kind of a pre-phase study comparing sonrotoclax and zanubrutinib. So this is the first really nice data set with sonrotoclax, not venetoclax, sonrotoclax for these patients. 137 patients were treated. Again, these are newly diagnosed patients receiving treatment. High rates of MRD negative remission for these patients, combining sonrotoclax and zanubrutinib. And look at the PFS curve; it's practically flat. Again, with 1.5 years of follow-up. So short follow-up, but this actually is a regimen which could be quite important when and if it comes back. And ultimately, the question will be how much sonrotoclax is better than venetoclax, and I think that's kind of still up in the air. But nonetheless, if the phase 3 is positive, it will lead to, for the first time, an approval of a new BCL2 because we only have venetoclax. So then we will have sonrotoclax available as well for patients. So we are looking for this trial to read out, which is still, I think, a few years away, but at least the trial is kind of fully accrued. And my last data set is I want to show you some data which we presented at the ASH meeting. This was using pirtobrutinib. So we have talked about ibrutinib, zanubrutinib, acalabrutinib. Obviously, pirtobrutinib is a non-covalent inhibitor which is approved in a relapsed refractory setting. So we argued, and it works great. It works for ibrutinib failure patients, and it's pretty safe. So we argued, can we bring it in the first line setting in a time-limited approach? And maybe that would be, lead to better outcomes for our patients. And that was the argument for this study was. I won't go into too much in the design. It's just a 1-year triplet combination. We enrolled 80 patients at MD Anderson. Median follow-up is about 12 months. But this was the interesting part, which is actually quite intriguing. So we did actually clonoSEQ, because clonoSEQ is a NGS MRD assay. Flow cytometry, as you know, goes to 10 to the power minus 4. clonoSEQ goes to 10 to the power minus 6, 1 in 1 million. We checked this assay in blood and bone marrow after 6 months of therapy and after 1 year of therapy. Now the green here is clonoSEQ negative at 10 to the power minus 6. So if you just focus here in the bone marrow, in the blood, at end of therapy, 85% were clonoSEQ negative at 10 to the power minus 6. 80% in the bone marrow were minus 6 negative. And if you club minus 6, minus 5, and minus 4 together, which will be, your traditional definition, 10 to the power minus 4, practically everyone was MRD negative. So we were quite happy and to see that many other studies have shown very high rates of MRD remission, but the fact that majority of these patients are MRD6 negative is like really makes us believe that hopefully we'll see a very durable long-term PFS for these patients. So we are continuing to enroll patients on the study and continue to follow these patients, but the data continues to look actually quite good. As I mentioned before, anytime you use doublets and triplets, you have to think about neutropenia, 60% neutropenia in this study. But again, if you use growth factors, that was pretty manageable. So my conclusion slides before we go to the Q&A. I think BTK monotherapy is fantastic, and it has done a lot of good for us over the years. But I think with these time-limited approaches coming along, I think BTK inhibitor monotherapy will likely go away still, but for patients with P53, I think that is still the best approach that we know of outside of a clinical trial. And certainly you can argue older frail patients where you don't want to give venetoclax-based therapy. Maybe patient has some renal failure. Maybe they have really big lymph nodes. You worry about tumor lysis, admission to the hospital. I think it's just easy to initiate. So that certainly will remain there. But again, the problem is it's a lifelong therapy, which, and cost and AFib and whatnot. Venobin has been fantastic and we use it all the time. I do believe that and I should say will likely get replaced, not for all patients, but I think large number of patients and the clinicians will move to Acala-Ven just because it's very easy. 2 pills, no infusion. You start with Acala for a couple of months, then you add Ven. The risk of tumor lysis goes down substantially. So logistically, it's much easier, and I think that will be what many of the clinicians and the patients will say. It's let's do that. Ibrutinib and doublets and triplets, I think with ibrutinib and the toxicities which we know with ibrutinib versus second generation, I don't think these studies will go anywhere. It is approved, but I think people will start using Acala-based therapy as opposed to ibrutinib-based therapy. These studies will provide some nice long-term data, the ones we and others have done in the past, but I don't know if people will be using ibrutinib doublets and triplets when we have access to second generation doublets and triplets. Now, there are some caveats to second generation doublets like Acala-Ven. MRD rates are not as high as ibrutinib-Ven. But will that sway patients to use ibrutinib for their patients? It's possible, but I think that still is a question. As we discussed, based on the Amplify study, Acala-Ven with and without obinutuzumab expected to be approved maybe next year. I think a lot of physicians will, as I mentioned, will start using it, though there are some caveats to it. As we discussed, MRD rates unexpectedly are not as high. Zanus and Rhodoclax, the data I showed you, preliminary data, looks quite exciting. The randomized study is fully accrued. We're waiting for the results. It's still a few years away. Obviously, we don't know what the results will be, but if it is positive compared to obinutuzumab, then that would really make Zanus and Rhodoclax one of the important drugs in the field. Pirtoven is also being studied in the frontline setting. I quickly skipped over the slide called CLL18 trial. That is still, again, some time away. Even if it's a positive study, it's still like 3-4 years away. So that is still kind of some time away. But I think the immediate approach will be when Acala, or immediate approval should be when acalabrutinib. And my last slide here, I think we talked a lot about frontline therapy and different permutation and combinations you could use, right? You could start with a covalent inhibitor, continuous BTK inhibitor therapy. When you fail that after 7, 8, 9 years, you can move to a venetoclax-based therapy, and then you achieve a treatment-free remission, and then you can use some other therapies. Or you can start with time-limited approaches, as we just discussed, and follow up with them with either a BTK inhibitor or reuse the BCL2 inhibitor and use ibrutinib, Acala, or Zanu in a later lines of therapy. So, and there are multiple other combinations you can think of for these patients. But the point here is that we're talking about long remission durations and years of survival, which is fantastic. So it also becomes problematic when people talk about sequencing, that how are we going to sequence them and which sequence is better, because it's very difficult to do a trial which runs for like 15 years, because By the time you are doing the trial, field would have moved on with a new BCL2 inhibitor or a new BTK inhibitor or a BTK degrader, and your trial will be really obsolete. So because the field is moving so fast, I think sequencing is kind of difficult to do, sequencing trials. But the fact is that the patients are doing really, really well. In my opinion, any of these strategies, I think, will really lead to very favorable long-term outcome for our patients, irrespective of whether you start continuous BTK inhibitor or a time-limited approach. But I do believe time-limited approach is the way to go, given the cost effectiveness, high rates of MRD, and the patients, are done with the treatment. And we have now excellent data, some of which I showed you with these time-limited approaches. All right, I will stop here. I think we're good on time and happy to take questions from the group. Thank you.
Thank you, Dr. Jain, for that excellent presentation. You covered the entire spectrum of CLL treatment, and very, very interesting to see the new data and what's going on in the field and where CLL treatment is heading to. So we'll start with the question and answer session. I would also request Dr. Anusha also to chip in because she sees all our CLL patients, and I'm very sure she has quite a few interesting cases to discuss with you. So to start off, we have collected questions from all our colleagues across the country, and one of them, I mean, this quite echoes what you had discussed in your presentation also. But in patients with high risk features, IGHV unmutated, deletion 17p, TP53 mutation, do you think time limited strategies can be applied, or is it only indefinite treatment? Or should it be a combination of both?
Yeah, so I think I view them 17p and p53 as one bucket. And in fact, I have the separate slides, another 10 slides, which are in this, which I knew we won't be able to finish on p53 specifically. But just to give a nutshell, I think for p53, we have very limited data with time-limited approaches. And I do believe right now, unless we know more, continuous BTK inhibitor is still appropriate standard for 17p p53 patients. So I think of them as one bucket. Mutated and IGHV unmutated, I view them as differently. And I think IGHV unmutated, I think time-limited approaches are reasonable approaches to do. Because the data is, numerically maybe 10, 15 percentage point lower PFS, but still it's a decent PFS. It's not like a 5-year PFS of 20%, or it's still 5-year PFS of 50, 60%. So I think in my view, unmutated or mutated patients for sure, time-limited approaches. Unmutated, I think is very reasonable, and that's what I do. But p53 deletion 17p, I put them separately, and I think for them, I think we're still not sure if time-limited would work. Our I plus V data for 2 years looks actually pretty good. But again, we're talking about only 27 patients, so I don't make big claims about that. So I think unless we have more follow-up, more number of patients, I would, for 17p, I will stick with the continuous BTK therapy.
Sir, actually, practically, we've actually started offering the combination and time-limited strategies to the higher risk patients. So that might not be the way to go about it, because almost 90% of our patients are on a single agent BTK, and very recently only we have started offering this, sir. But again, we tend to offer it to the most high risk patients.
Yeah, so I think as I said, I think 17 PP3 patients, I think now an organ could be, let's suppose, and when you say time-limited approaches, is it like ibrutinib venetoclax or acala venetoclax? I know because acala, I think, is maybe easier available these days than ibrutinib in India.
Actually, triple, acal, obin, and ven for young high risk patients in
Right.
40s and 50s.
So I think if you're using triplet, acalavenobin, the data from Amplify, which I showed you, for mutated and unmutated is fantastic, actually. The curve got lower because of the COVID deaths, but that's maybe not a concern these days. So the triplet of acalavenobin, so because that the study included those. For 17p, I'm still concerned, and I'm not clear in my mind if 1 year of acalavenobin or ibrutinib will do the trick. I think for these patients, either you need longer, you do the acalavenobin, but you check MRD and then you continue longer. Again, that's not trial driven, but that's, at least maybe 2 years of therapy as our group did. That may be reasonable. But I think 1 year may not be sufficient. Now, unmutated V gene patients, I think I'm completely fine with doublets, with acalaven or acalaven obin. Again, with acalaven, the PFS is slightly lower for unmutated V gene patient, and again, I was hoping it will be higher, but there is always complexity of the data. That the data doesn't match exactly what you want it to show, and that opens this discussion point, as you were saying. But but for unmuted, I'm still fine because you can always, retreat them because you're not doing 5 years of acalaven, right? You're doing 1 or 2 years. And if they
Right.
were to progress, then you can put them on continuous BTK inhibitor, right? Like
Okay.
continuous acala or Zanu. So, because they will not be resistant to it. And I have multiple patients, several patients doing the same thing where they progress after I plus V because we have much more experience with I plus V. And then I put them on Akala at that time because just ibrutinib toxicities, and they're doing absolutely fine.
Right.
Continuous Akala.
So practically recently when we have started using Obin, we see that some patients the TLC just crashes, the leukocyte
Yep.
count just crashes, and in some patients it's very gradual. Does this have any implication, prognostic, or anything otherwise?
So good question. We see the same thing. For some patients, white count come down so dramatically, like unbelievable amount, even with 100 milligram of like test dose. But for some, it's slow. I mean, potentially it may. I mean, I don't think anyone has ever studied that. In all fairness, because there are multiple other factors, which come into play, and we are not tracking these white count and the slope of white count that clearly or closely. But yeah, I mean, I think you would maybe think that patients who are very sensitive to Rituxan, their disease is coming down sharply, and others may not. But maybe difficult to kind of make a point about it, especially if you're using combining it with BTK inhibitor at the same time. If you're using single agent Obin for the first month, like if you do Veng, you for the first 3 weeks is single agent Obin, then you expect counts to go down. But there are still some patients in which it will go down. When you're using Akala Obin together, like from starting day one, because as you know, Akala causes reactive lymphocytosis, maybe there is some Akala trying to increase the white count, Obin trying to lower it. Maybe there are some patients in which it will have a slower drop in the white count. But again, that is not, as far as I know, studied prospectively for patients.
Right.
Uh,
So
so, doc-
practically, by when are you able to introduce the Venza? Do you have always on the second cycle or much later? Because that is also seeming very variable in our patients.
So we tend to follow, in all fairness, the CLL14 style, where the Ven is introduced on cycle 1, day 22, but there's no right or wrong here. Many times I do it cycle 2, day 1. I have a recent patient who's having some skin cancer, some surgery requiring. I didn't want to do Ven right away, so he's like cycle 4, day 1 already, and I'm going to see him after holidays and start him on Ven. But generally, it's about end of cycle 1, start of cycle 2, in that ballpark.
Right. So one practical question deviating from the time limited thing, do you always require 80 milligrams of methylpred? That seems like a lot, especially in patients who are prone to infections as pre-medication. Do you ever deviate from that?
For
Especially in
Obin,
psych.
for
Yes,
Obin.
yes. Yeah.
So we just do that for the day 1 and day 2. But if they have no reaction, because practically no one has a reaction on day 8 and 15. All the reactions are in day 1 and day 2. So our Obin is for day 1 and day 2. And if no reaction, there is no Obin later. Oh, not no Obin, sorry. No steroid later.
Okay.
So pre-med with steroids is only for day 1, day 2. Now, but many times, there are some patients who had some reaction and then they will ask, oh, can I get some steroids because I'm worried about reaction again. So you don't need to give 80, you can give 20 or 40. But really, many times we just don't do at all because they did fine with the cycle day 1 and day 2.
Right. So in any of these combination therapy, do you find any difference in response in patients who have an SLL-like disease versus a patient who had a treatment indication for a CLL-like disease?
So, we treat them the same in a way. So, I mean, most studies will have 5 to 10% of patients will be SLL, all others will be CLL. in the world of CLL, SLL, we are really not making a distinction between the two. We are managed them the same way, treat them the same way. Whether there will be a difference, SLL patients with bulky lymph nodes, it's quite possible if you have a study with a SLL patients with very bulky lymph nodes, and you do treat whatever treatment you do, they may not achieve a complete remission because their lymph nodes may still be slightly bigger than 1.5 centimeter, which is the cutoff. But overall, I have not seen any study reporting difference in the outcome between these patients or long-term differences. So now SLL patients, lymph node based patients, most likely, more likely to have 11q deletion and unmutated B gene. So that may also play a part in terms of long-term responses. But in general, we don't really think of them as separate diseases or view of them as separate in terms of duration of remission or PFS.
Right, sir. Sir, again, deviating from the time limited or treatment, but the question is, what's your experience with CNS disease and CLL? So very recently, we had a lymph node predominant disease with new onset neurological symptoms, had a squint, and then went for an evaluation. We initially thought there was a Richter, but then we
Yeah.
biopsied the cervical nerve root, CSF was done, cell was CLL morphology, flow was CLL morphology, and biopsy also did not show any Richter. And he had no other treatment indication. Blood TLC was just about 5,000 to 7,000, and he had a very lymph node heavy disease.
Yeah, so I mean it's quite rare. We occasionally see them. It's not that I can tell you we have seen 50 of these patients, but we're talking about a handful of patients. And I would say the practice pattern has been very varied, from just using intrathecal chemotherapy plus ibrutinib or any of the BTK inhibitors, to using more like a CNS treating as a CNS lymphoma kind of a thing with high dose methotrexate, systemic methotrexate. So I don't know if there's a right or wrong answer here. I think I think if there's a CSF involvement, I think intrathecal chemotherapy, along with a BTK inhibitor, which will have a systemic control of the disease, I think may suffice. And if that doesn't work, then maybe you have to treat it more as with high dose. You can use Part B of hypercvad or as treat as primary CNS lymphoma. But again, I don't think there's any good literature in that regard per se.
Right. So actually, OBIN, BTK, and BCL10, all of them have CNS penetration. So
Yeah, I mean, you can. So, in all fairness, yes. I mean, you can use any. I mean, I think in the few handful of some of the patients I have seen, and I don't recall seeing anyone recently, maybe a year or 2 year ago. We just put them at that time on a BTK inhibitor, and the patient just is doing fine. Yeah, so, but I think, yeah, I mean, I think you could consider a more intense. It's fine, to do triplet or doublet as well. I don't think there's certainly not wrong about it. But some of my experience, I've just used BTK inhibitor. But yeah, I mean, it's not a large volume experience to say that I have.
right, sir. Thank you.
Uh, Outside of a clinical trial, at what time points would you recommend measuring MRD, and how would you modify your treatment according to the MRD results?
So this is a kind of no right kind of an answer here. So obviously MRD measurements may be important in time limited approaches, right? If you're using ibrutinib alone, not really needed. They will not become MRD negative. So if you're using a time limited approach, just for the sake of argument, if you're using ven or benitumumab, I tend to do MRD in the peripheral blood. As you know, it's a 1 year regimen. I do it at 6 months. Then if the patient were to come back at 9 months to Houston, then I did it 9 months, but many times they are with a local doctor. And when they come at end of treatment at 1 year, I do MRD. If MRD is negative, I mean, in frontline setting, in all fairness, if MRD, irrespective of MRD, I tend to stop therapy, because thinking that even if it's MRD positive, and if patient does not have high risk features like 17p or p53, they will still have a decent PFS, and I can always retreat or do a BTK inhibitor at the time of relapse. So I'm kind of less inclined to increase the therapy based on MRD for VenG, because there's not much data in terms of increasing the VenG may improve outcome. On the flip side, if I'm using ibrutinib ven, where we have a lot of experience, we have and published and shown that if you're MRD positive at 1 year, and if you continue second year of I plus V, half of the patients who are MRD positive will become MRD negative after second year. So we tend to do that, prolong the treatment for I plus V based regimen. In the relapse refractory setting, I think the ballgame is a bit different, and especially if you have a multiple relapse refractory patient. There, I check MRD, and if MRD is positive, I'd have continued venetoclax longer. I have some patients who are on venetoclax for 4 or 5 years and taking it now. That's not maybe truly evidence-based in that sense, but I think it kind of intriguingly makes sense because I'm just worried if I start venetoclax and they've already failed chemo in the past, then ibrutinib, and I just worry that they will have a bad outcome, and I just want to keep them in remission the longest I can. So yeah, I mean, I think MRD-guided therapies in general are not FDA approved to say. I think this is just the practice pattern I have used.
So if a patient turns MRD negative at the end of 1 year and you stop treatment, then how often do you do their peripheral blood MRD? And in such patients, do you recommend doing a bone marrow MRD, or is it only peripheral blood MRD that you do?
Yeah, I've stopped doing bone marrows for these patients outside of a trial setting. So I just do peripheral blood MRD. My general thinking is whenever they come back to the clinic for follow-up, we tend to do it, every 3 to 6 months time frame. They come back to Houston to see us. And so I don't think you need to do monthly MRD, but I think every 2 to 3 months or every 6 months would be appropriate. Certainly that can create, because you're not likely going to act on MRD. It's not that if you come MRD positive, you're going to start them on treatment. So then that becomes an argument. A counter argument is, why are we checking it if you're not going to act on it? And if you check it and it's positive, then the patient will be upset or disappointed, or maybe if they're knowledgeable about MRD, and it will create unnecessary anxiety everywhere. So why to check it if you're not going to act on it? Now, for me, it's acting on it in the sense that many of the patients who come to us, they're kind of many times knowledgeable, they want to get it done, and we can see the trend for MRD and things like that. Arguments are both ways, as I said. Some people may say, "What's the point?" But yeah, if you're checking it, don't do bone marrow. I think peripheral blood is more than sufficient.
In patients where you use venetoclax later on in the treatment cycle, either after acalabrutinib couple of cycles or after 1 or 2 cycles of obinutuzumab, do you think the ramp up schedule, the very slow ramp up schedule of 20, 50, 100, should that be followed? The reason I'm asking is in India, we have venetoclax of only 100 milligram strength available as of now. So, if the disease burden is less, or if we are giving pre-treating patients with either acalabrutinib or obinutuzumab, should a strict ramp-up schedule be followed, or can we introduce venetoclax a little more quickly?
Yeah, so I think, people have done rapid ramp up of, obviously the standard would be to do weekly ramp up. There have been studies like for Richter's, we do daily ramp up. For venetoclax, we use in ALL patients, we do daily ramp up. Obviously, AML, it's different. I mean, it's fast ramp up as well, or practically no ramp up. So I think uh, as long as you're monitoring patients closely and they don't have a big tumor bulk, I think it's appropriate. Now, if you do a daily ramp up, I would obviously advise that daily they should be checking their labs, hydration, and things like that. So it can be, if you're doing Monday to Friday or Monday to Saturday, whatever, it can be patients coming daily and they're getting their labs checked and things like that, which may also become a bit logistically cumbersome for the patient. Many times just coming once a week, like every Monday, every Tuesday, maybe just a bit easier depending on how far they're traveling. So there have been studies done at single center studies. I think Dana-Farber had one study, Ohio State had one study, maybe City of Hope as well, where they have done rapid ramp up for CLL patients within their own institution, and that seemed to be doing okay. So fine. So I think it can be done as long as you're monitoring patients closely. And again, certainly we do it for more aggressive histologies like Richter's and ALL.
What is your antimicrobial prophylaxis for patients on obinutuzumab, venetoclax, or BTK inhibitors?
So our standard is just to use valacyclovir or acyclovir. Just does that. That's it. No need for Bactrim. No need for obviously voriconazole or POSA, because that will change the levels of ven anyways, and it will be difficult to manage. Plus, you don't need it. So we only use Valtrex or acyclovir. I would say that has been our practice for the longest time. And I know recently some other discussions with some centers in, or many centers in the US actually are not even using that, because the argument is that was more important when we were using fludarabine FCR based therapy. And now that patients are not exposed to them because they're starting BTK or VEN as a first line therapy and never are exposed to chemotherapy, do we really need to give them Valtrex prophylaxis as well? So I tend to use it still, but that's the only prophylaxis we use. No other. And besides, allopurinol, but not antimicrobial prophylaxis.
On a related note, sir, we
Yes.
managed to give all our patients the first dose of vaccination. Here, even patients don't get routine flu vaccines yearly. Mostly they come with a treatment indication, and that's when we tend to vaccinate them. We managed to get in the first doses, but then the later doses are always after exposure of the drug. And it's more concerning, especially in case we are using CD20 inhibitors. Does it matter? How do we go about it?
Well, I think you have. I mean, if patient could get the vaccination, because most of the time, as you know, CLL patients, it's not that we must start treatment tomorrow. Always there is some flexibility of when you want to initiate treatment. So I would say that we tend to follow their disease, and whenever they need treatment, we try to get them started. If they get vaccinations beforehand, it's good. If it could be delayed treatment by 1 or 2 months, I think it's okay. But many times, you also don't want to unnecessarily delay treatment for patients who need, for CLL. So we kind of tend to do them as separately. If they need treatment for CLL, sure, let's get started. Or they haven't had vaccination, let's try to vaccinate them before. But I'm not delaying treatment for 2-3 months just solely on the basis that I need to get the vaccinations in. But again, it's also the risk of infectious complication within your geographical area, to say, of viral infections.
Right. Okay.
We have actually received quite a few questions on drug toxicity and its management, but in view of paucity of time, I'll summarize a few concerns that have been raised. First is with BTK inhibitors, if patient develops any bleeding manifestation. Number two, atrial fibrillation with shock. Can it be reintroduced, and if so, after how often?
Yes, I think it depends on the severity of obviously the bleed. I mean, if it's just a minor bleed or some skin bruising and skin bleeding, I think it's okay to reintroduce. If it's a CNS bleed, I would never reintroduce a BTK inhibitor. If it's atrial fibrillation, I think I tend to decrease the dose when I reintroduce, like maybe a couple of weeks later once they are more stable. Now, many times what happens with AFib particularly is that they will be on anticoagulation or something by the cardiologist. And then that adds to the complexity of reintroducing the drug, but I tend to reintroduce at a lower rate. Now, also, it depends on how far the patient has been on treatment. Let's suppose a patient has been on ibrutinib or acala for like 7 years or 5 years. Their disease is excellent control. Many times in those situations, actually, I give them a treatment-free holiday. I said, okay, let's just, you get your AFib under control. We'll just continue to watch you, see you every few months. And, there's data to that effect that once you stop BTK, average remission, time to next treatment could be 2-3 years. So they could get some time off therapy before I have to reintroduce either the BTK or venetoclax. But if it's earlier in the course of the disease, you just started ibrutinib, it's like 3 months into it, they have an AFib. In that situation, I would reintroduce ibrutinib at a lower dose, easy to drop the ibrutinib doses, and then kind of continue that. If they have a recurrent episode, in that situation, I really try to go to now the venetoclax-based therapy.
And if a patient develops a serious infection on venetoclax, especially during the ramp up schedule, how much of a break do you give them before restarting venetoclax?
It's very flexible. There's no, again, right? I mean, I have patients in which we have waited a few weeks, and or sometimes there are logistical challenges. So they started the ramp up, they develop neutropenia, some infection. We give them growth factor, control the infection. 2-3 weeks later, we resume the ramp up. Sometimes it can be longer as well. So I think you can certainly wait. There's no, I mean, if there is an infection and neutropenia, don't keep pushing the venetoclax dose. You can wait a few weeks and then resume it.
Right. Until now, our standard practice at baseline as well as relapse has been to look at a IGHV mutation as well as a CLL fish, which includes the normal abnormalities. But in your practice, do you use NGS for all CLL patients outside of a clinical trial? And if yes, do you think that can really replace a fish panel?
So, we use three tests. So we use IGHV testing, which is a standalone testing, a DNA-based method, sequencing method. Then we do CLL fish panel, and then we have a next generation 81, actually a lymphoma mutation panel, which has P53, SF3B1, all the lymphoma, MYD88, and other mutations for it's what the lymphoma group uses for their DLBCL patients, basically. But it has all the CLL relevant mutations which have been added, including P53, SF3B1, Notch1, also BTK, BCL2, PLC-gamma2. So this had 176 genes. So we run that panel for everyone. So the mutation panel for DNA sequencing of these specific mutations, IGHV panel, and FISH panel. Now, unless there is a genomic test which can cover everything in one assay, because FISH is a different assay than these other tests, and FISH is very important. So yes, you can do, I guess, array CGH or some other methodology, but as far as I know, if you just can you get everything, all these analysis done in one single assay? It's possible. I'm not aware. I'm not in the pathology and molecular lab, so I'm not aware of that. So these are three standalone assays which we do for patients. But I think these all are important because, as you know, deletion 17p by FISH and P3 mutation by NGS sequencing, they have the same connotation, but one patient could be one or the other. So, you really need to do P53 mutation assay, which for us is part of this bigger 176 gene panel. You need to do a CLL fish panel, and then you need to do the IGHV testing. And there are three different tests, but they're pretty come back within a week for us. Fish panel generally comes back in 2-3 days. IGHV testing and lymphoma gene panel comes back within a week. And generally for CLL patient, it's not an immediate rush that you need to know in like day. It's not like an AML, you need to know IDH2 status or FLT3 or whatnot. So for, it's practically, it's working out well, but those are the three assays we use.
And there has been a lot of discussion regarding other high risk markers like Notch1 and many others based on the NGS. Are the recent clinical trials looking at risk stratification based on any other markers other than IGHV mutation and TP53?
Yeah, so our panel also has the Notch1, SF3B1, all these mutations, but none of the trials. So there was some data, if I recall, with the CLL14 study, or maybe it was a few years ago, that the Notch1 patients may not be doing as well. But never, maybe one study will show it, but then others don't really show it. So I don't think any of these other mutation panels have been shown to impact treatment outcome or treatment decisions. There's some associations over the years which we know. For example, Notch1, higher risk of Richter's transformation, some other earlier studies have established. But again, that was in the context of chemotherapy. If I'm using non-chemotherapy, if I'm using ibrutinib, does Notch1 causes more Richters? No, because anyways, Richters are becoming much less. So I think these other mutations may be okay to know, but if you have priority and you can only check certain mutations for financial reason or whatever, I will focus on P53 mutation, FISH, and IGHV, and I will skip all others.
Great. I think that's been our standard practice as well. There's a
Yeah.
question in the chat box from Dr. Sham. 80-year-old CLL with WBC count of 2 lakh, hemoglobin 7, platelet 30,000, DCT positive, normal cytogenetics. What is your preferred first-line treatment?
So this looks like a patient is anemic, like immune hemolysis here. So in these patients, I tend to treat the immune hemolysis first with steroids and rituximab, settle the hemolysis down within a few weeks to a month. Generally, their hemoglobin improves. Obviously, with rituximab, the white count will also come down a bit. And then I generally start CLL-directed therapy. Now, this patient has elevated white count and maybe it has lymph nodes as well. But if it's just an isolated immune hemolytic anemia, I treat the immune hemolysis, but then I don't start CLL-directed therapy, I just watch. But if it's a second episode which happens, or if they have a concomitant big lymph nodes, white count is, very high. It looks like this patient also has thrombocytopenia and whatnot. In that case, once you stabilize the autoimmune hemolytic anemia, then I start with the serial therapy, which many times is a BTK inhibitor, which works very well actually, and it controls. I have patients with recurrent immune hemolytic anemia, started the BTK inhibitor after controlling the immune hemolytic anemia, and then no further episode for the next 5 years. But previously, the patient had multiple episodes over like 2-3 year time frame. But at the same time, I think if you want to use a time-limited approach of Ven-G, once you stabilize the autoimmune hemolytic anemia, I think that's fine. It will control get the clone away, and you will not have recurrent episodes. So I think CLL-directed therapy could be decided at that time, once you control the hemolytic anemia part of it.
So very often with cytopenias initially immune mediated versus a CLL related cytopenia becomes sometimes a little difficult to distinguish. So in such
Sure.
patients, would you do a bone marrow to really look for CLL involvement and say, okay, this is maybe CLL not immune mediated?
Yeah, so our standard practice has been, before I start any patient on first-line therapy, I do a bone marrow biopsy and also do CT imaging studies. Now, many people don't do bone marrow biopsies, or many centers, but I do at our center. This is our standard practice. Also, again, as you said, just to make sure this is all packed marrow with CLL, not make sure that there is no MDS from prior FCR 5-7 years ago. So we tend to do bone marrow for everyone who's starting treatment with us. But I will say, even in the US, patients are coming to see me for a second opinion, and they say my doctor was just going to start a calabrutinib without a bone marrow. And I said, that's fine if that's what they want to do. But if you were getting treatment with me, I will do a bone marrow first before I start you on first line therapy.
Right. I think Dr. Srinidhi has a question. Are you, yeah, you can directly come in, Dr. Srinidhi.
Hello, sir. Good evening. So I'm not a clinician and I'm from the molecular diagnostics, molecular hematology background. And so how important is it that, the common teaching from my training days has been that we have to report the CLL stereotype, what is detected on IGHV analysis? How much importance does it hold clinically, whether we report or we don't report? And the V321 as well.
Report IgG mutated, yes or no, or what? Sorry, what were you saying?
CLL stereotype.
The CLL phenotype or the subset of IgHV, you're saying?
Yes, so like CLL1, CLL5.
Oh, okay. So this is an area which has not been very well studied. So in our group also, we really used IgHV mutated versus unmutated, like a broad strokes. Now, I would say in the last couple of years, our lab does report CLL subset, like family 169, or different family members. They've started reporting it. They were not reporting it previously. Previously, it was just mutated, unmutated, and they will say percentage difference from germline, like 0% or 5% or whatever. At the Soho meeting a few months ago, there was a Meet the Professor session where we were discussing exactly the same thing you're asking. What is the relevance of these subtypes? And I think the data from Europe, where they have done most of the work from the Spanish group, in these subtypes, I think it's still a work in progress. I don't know so it's not that, if I have a specific subtype, I will say, I'm going to use a BTK inhibitor for this patient. I make that decision based on, as we discussed in the talk, mutated versus unmutated. Subtypes may be important, but again, it's quite possible, because our therapies are so effective these days, that whatever the subtypes had some influence is getting negated by such effective therapy. Same thing, if we have really effective therapies, the prognostic markers which were relevant before may not be relevant anymore. So we do have that data for these patients, but again, we don't really use them clinically, at least in our center.
So I was the central lab when we did that Calcone study phase 4 in India, and we sequenced close to 120 patients where we did FISH and IGHV analysis as well as the mutation analysis, and we found that the genomic landscape of Indian CLL is completely different, because our TP53 percentage so these are all relapsed refractory. No, sorry, these were all treatment naive, and our TB53 was close to 28%, and even the ATM mutation was 30%. So, how different would you think is the response to treatment, and how clinically and how therapeutically important it is? Because some of them who had a ADM mutation did not have 11q. So it was not correlating, and even the mutated, unmutated, the typical teaching is that it is supposed to be 50-50%, but in ours it was like 39-61. So just
So
to highlight
that's
the
not
Indian.
yeah, I mean, so certainly I think it just maybe depends on the referral pattern, right? Where these patients are. And I think you guys obviously see when they come to you or to a center which had that trial or whatever, they may be much more aggressive disease state. And that's true for, I think, many of the diseases in India, patients present at a later time point. I think we don't really think too much about ATM mutation. I mean, deletions. So P53 mutation is important, but ATM mutation, we check it, but we don't really care about it. 11q deletion is important. So the connotation of 17p deletion and P53 mutation, which have a similar meaning, deletion 11q, yes, is associated with ATM mutation, but we don't think of ATM mutation as the same involvement at all. So in fact, we don't even report in our studies of ATM mutation how many patients are ATM. No one asked for it because, so ATM mutation, I think is not relevant. And then IGHV status, yes, most of the studies in the CLL in the frontline setting, the IGHV status, in fact, the Amplify study I showed you was like 60% IGHV unmutated. So most of the studies will have 55 to 60% unmutated. So having 61% is fine. But it's only higher rate of P53, which you commented 28%, which again is just maybe a referral pattern to wherever these patients went to.
Thank you, sir.
I think with that, we have come to the end of all questions. No further questions in the chat box or from any of the participants. So, Dr. Nitin, it was wonderful interacting with you. Last hour and a half almost. We are well past time. But it was an excellent session, and you patiently answered all the questions. Many of them, no clear clinical answers, but yes, have very significant implications as far as routine clinical practice is concerned. So, thank you once again for joining us and delivering this excellent talk.
Thanks a lot, guys. Have a good night, and hopefully see you guys around in New Year time someplace, or maybe on the next webinar. Take care. Thank you, Nikhil, for hosting it.
Thank you so much. And
Thank you.
before we
Bye.
wind up, I also would like to thank MCure Pharmaceuticals for providing this platform for conducting this webinar. And I thank all the participants from across the globe who have joined in for this webinar and sparing their time on a Friday evening to join us for this academic webinar. We hope to catch up next month with a webinar on DLBCL with CNS involvement with Dr. Priyanka. That would be on the 17th of January. Once again, thank you all for joining in, and thank you, Dr. Jain.
Thank you.